who is working here in the Sligo area. She used to be a colleague of PS as a health economist at the University of Oxford, and thankfully has come back to Ireland because we are very, very short of health economists. I think there's about 10 in the whole of the island of Ireland, and it's brilliant that we have you back. So you are heading up Department of Health Nutrition Science at this university, but your whole area is about health analytics, evaluation and policy. So a huge area of professional expertise. But why we want throughout this day, if you've glanced through the whole programme, is we do have some people, we call them patients with experts by experience. And certainly in my area in diabetes care, we can't seek funding now. They have to be driven. You know, it's not for a clinician to decide what the project should be. Everything has to be fed from the experts, the people who know the conditions. So through this program today, we have some of these experts by experience of different conditions. So it's kind of you to share some of your insights, and we're delighted to have you on the thing. And of course, you are part of the conference committee. 15 minutes.
Thank you. And thank you, PS, again, for coming. I think we all enjoyed that talk. So my talk today is from a patient's perspective. So I'm not going to talk about, well, I'm not going to explicitly talk about health economics, but it is hard to untangle. So, where are we? Yes. This one. Nope. All right. Here we go. Yes, so just to highlight, I do wear a lot of different hats, and as a long-term patient, having a disease since I was diagnosed first when I was 12, but symptoms before that, it has informed my trajectory in terms of my, I suppose, life path. So it is hard to talk about a patient experience without colouring that with a bit of my research background, the health economics piece, the health policy piece. So although I tried to make this presentation as less academic as possible, unfortunately the academic is shining through in the presentation. But the patient journey for me started when I lived in the States when I was 12 years old. And I suppose I would have been symptomatic for several years before that with Crohn's disease, inflammatory bowel disease. But as a child, you don't know you're sick. You know, you have stomach aches, you have weight loss, you have lethargy, you're talking to your parents, but you don't really know how to express what your symptoms are anyway. So, oh, you have a stomach bug, oh, you have this, burning. You don't know the word indigestion. Nobody told you what indigestion is, so you don't know how to express those feelings. So childhood illnesses are particularly difficult to get diagnosed because the child themselves doesn't have the language to express all the symptoms that they're experiencing. So it did take several years before I collapsed one morning in a restaurant after eating something. It was a Tex-Mex restaurant. We were living in San Antonio at the time. And I ate something, a breakfast burrito type thing, collapsed, rushed to hospital, ulcerations from the back of my throat all through the GI tract. And at the time, the Children's Hospital in San Antonio had never seen anything like it. They thought it was some rare form of AIDS. They had me in isolation. They didn't know what to do with me. It wouldn't have been a disease that was as common in the States at the time as it would have been in Western Europe. So through, I think, several months of investigation, doing some family background, I had an aunt that had diagnosed with Crohn's disease. They finally were able to start treatment and to start to control the disease. So that basically changed the whole pathway of my life, because in terms of understanding what a chronic disease was, and that would be lifelong, for those of you who don't know about inflammatory bowel disease, there is no cure. There is bouts of activity, remission, extremely unpredictable. So in terms of the patient journey, for myself and for all patients with inflammatory bowel disease, there's four key, I suppose, areas that we kind of need clinicians and all healthcare providers that are involved in our care to understand, and that's our particular care needs in terms of our symptoms, our clinical symptoms, the supports around us, not just healthcare professionals, but the wider network, understanding us, because sometimes we don't know how to articulate what we need, and all the constraints. So I have a job, I have a child. Most of you see me running around here this morning like a headless chicken, but I'm also managing a chronic disease in the background. So what you see outside is definitely not what you see inside. And that's the case with most people with inflammatory bowel disease. Even in remission, there are daily symptoms. You don't ever have a quality of life that's 100%, even in remission. So the clinical symptoms, I suppose, there's lots of different things, but the average individual, whether they're in remission or whether they're in disease activity, will have some degree of these different symptoms, and sometimes all at once. So whether it's Crohn's disease or whether it's colitis, you have all of these different symptoms that are, I suppose, the ones that are recognized, but then these can lead to lower immune systems. So you can catch all different types of infections a lot easier than others. And that can be whether you're immunosuppressed or you're not. So it's variable. Patients with Crohn's and colitis have a collection of these, none of these one week, lots of these another week. So it's very variable. It's quite invisible. You don't see it from the outside. It's all underneath, and it's very changeable, which means your whole way of living is uncertain. You wake up in the morning, you have no idea, will I be able to do my job? Will I be able to get in a car? Will I be able to just live a normal life today? Or will I have to stay in bed because my stomach is swollen out here and I can't eat today? So, and that doesn't necessarily mean that you have to go to the hospital, because your disease markers might be fine. You could just be having an exacerbated day. So those constraints I was talking about, depending on your medical background, you can have side effects from treatment. Depending on whether you've had surgery, I've been lucky enough in my lifetime only to have one minor surgery, not bowel resection, but seton placement for a fistula. So those of you who don't know about that, you're better not knowing. It's not something I want to explain. In terms of employment, just trying to do your job. I love my job. I love what I do. I won't give it up unless a doctor tells me you have to, otherwise you're not going to be able to function. But I want to do my job as well as I can, and that might even be an outcome of living with a childhood illness, that you want to still be a functional, productive member of society because you were told you couldn't. So it's, I'm proving all my healthcare professionals wrong, and I'm going to keep going. The financial stresses. So we're lucky enough in Ireland that we do live in a healthcare system that's highly subsidised by the government. Regardless of what kind of payer you are, you don't have to pay a lot. But that's not the case for people globally. There are different countries, different funding mechanisms. Drugs are expensive if you have to pay for them. We are lucky in Ireland. I think a lot of patients and a lot of people in Ireland don't realise how heavily subsidised healthcare is in this country, because obviously it's free mostly in the NHS, but we're pretty close to free with the fees that we pay here. Even if you don't have private health insurance and you don't have a general medical card or you're covered under GMS, the co-payments are marginal compared to what they're paying in other countries in the world. So we really don't know how lucky we have it in terms of financial. But then also family. I have a young son, and that is a picture I got from the internet, but that is a regular picture of anybody who has Crohn's or colitis that is looking after a young child, because that could be a reality some days. So in terms of supports, we do need lots of supports. We need more access to our healthcare professionals. And COVID was great I felt COVID was great because all my appointments were online. And this is brilliant. I don't have to travel 2 hours down the road to Galway. I don't have to get dressed. I can have my consultation with my gastro over the phone or through Teams. I love this. I want this. A lot of patients would be the same. Now, there are other patients that would like that face-to-face, but I think it's important to ask your patients what they want and try and facilitate that. Online work during COVID. Why can't online work going forward? IBD, as well as other chronic diseases, there needs to be more of a multidisciplinary focus. We need dietary advice. We need IBD dietitians. We don't have them, we need them. That's an area that needs to be explored with the HSC. Counselling. The stress and the psychosocial impact of inflammatory bowel disease is huge. Counselling is not part of the care pathway. It needs to be, because people don't elect themselves to go and get counselling for disease management. They have so much else going on. It needs to be part of the care pathway. It needs to be not only recommended, but required. You need to have an 8-month service, or 8-week session, so that you start to own your disease and you start to manage your disease. Family, friends, peers, without them you can't manage this disease. So if there are individuals that healthcare professionals identify as not having any kind of network, they need extra supports. So again, this idea of knowing who your patient is, knowing what their constraints are, knowing what the supports they need are. And the understanding piece is a big piece as well. And I'm realizing I'm running a bit close to the time now, but if you're a nurse, you have to train for 4 years to be able to take care of people in your day job, in a general ward or in any type of ward. Doctors train for a lot more. If people have long-term chronic diseases that they have to manage for the rest of their life, especially if they're diagnosed early in life, that's a full-time job. Where's our training? Where is our full-time training to allow us to manage our disease? Because it's 24/7 for the rest of our lives. We don't have that as patients. So where is that? And that should be something as well. We need to be educated. We need health literacy. We need to understand adherence. What really happens clinically if I don't take my tablets today or tomorrow? I miss them. Oh, it's grand, I'll take them in the morning. Medication adherence is a huge issue with IBD because there's so many different drugs. We have to take the ones at different times. So if you look at the studies of individuals, again, the academic coming in, but if you look at the studies of individuals with IBD and how long it takes them to fill their follow-up prescriptions, there's not a majority proportion, but there is a certain level of proportion that it is over 30 days. So individuals are not adhering to the medication that they're taking because they're overwhelmed, because there's so much to deal with. And sometimes if you'd have to take medication before you go to bed, and again, you're just too tired. You've gone to bed. Oh, I forgot, I have to go up and take. You don't. And that happens. And it's not that you don't, it's not that you're not cognizant of what you should be doing. It's just you're too tired. And then finally, the belief and the trust. So I've been a patient in 3 different countries, the US, the UK, and Ireland. I've also had 5 different gastroenterologists in Ireland, not because I chop and change, just because I've lived different places. And I've been suffering for this for 30 years. But practice is so variable. One gastroenterologist will prescribe one thing for the same symptom, another will do it a different way. Some gastros will do surveys at their follow-up clinics, others won't. If you're getting biological therapy or anti-TNF therapy, some will prescribe pre-medication for that, some won't. So what's going on? Why is this level of practice variation? If you're a patient that has the same gastro your whole life, you won't be aware of that. But we are very mobile. We move. We have a lot of people coming in of Ireland, going out of Ireland. The internet is just a click away. All you have to look at is the patient forms in the NHS. The length of time that those patients are on anti-TNF biological therapy is capped in terms of remission and status. In Ireland, if you're going on those kind of drugs, you don't seem to ever come off them. So why is this happening? Patients can access this information on the internet. They can see that my doctor is not doing something that's being done everywhere else. Why? Then you start to have belief issues. You start to have trust issues. And you lose faith in the process that someone else is acting in your best interest. So practice variation, I don't know the solution to that, but there are standards of care, there are recommendations, and healthcare professionals need to be aware that we, as patients, are using the internet. We are sourcing what's happening globally. If there are discrepancies or variation, it's up to you to explain us why. and not fob us off, because living with IBD is about juggling lots and lots of things. We want to have a life. In the background, underneath, there's so much ulceration, inflammation, symptoms, and you just want to have a normal life. But you need to be able to have the supports to do that. So, the confusion, the uncertainty, being able to predict what to do from day to day, there's a role for healthcare professionals to help with that pathway, to help demystify that process of uncertainty. And this is how the average person with IBD, where am I? I'm looking at the wrong thing. How the average person with IBD feels probably once a week. I don't want to have to do anything today. I want a day off. And reality, we don't get days off, especially if you have any other commitments outside taking care of yourself, which most of us do. So what adds to our anxiety, again, is this practice variation. If there are lots of different healthcare professionals telling us different things, how are we supposed to know what's right or wrong? So we need the multidisciplinary kind of teams to be involved in delivery of chronic diseases, not just IBD, but all chronic long-term conditions without cures. And we need people talking together, and we need them to also listen to us, listen to our questions, and not just listen to them, but understand us. Okay, understand why we're asking the questions, understanding that we have these constraints, we have these symptoms, we have these goals and these dreams of living a life without the disease being the main kind of instigator of our plans or our ambitions. So how do we transform IBD standard of care to IBD patient-centered care? There's lots of patient-centered care models. I've just got one here, but there are lots out there. Essentially, they're about bringing the patient in. They're also about multidisciplinary teams. They're about listening to your patients, understanding your patients, embedding your patients in the process, and treating the patient based on their experience. So yes, we need more capacity. Yes, we need more manpower. Yes, we need more people on the ground. It will take a huge injection of funding to be able to develop these care models across different chronic diseases. But what is the outcome? Better medication adherence, less admissions to A&E, less length of stays in hospital. Like PS was saying about the robotic surgery, it's costly, but look at the outcomes. The outcomes mean less healthcare resource use. It means better quality of life. So everybody needs a seat at the table. And that's where I'm going to finish. Thank you.
Thank you so much. And I suppose when we work with you, we don't see any of that because you're just so professional. It's all behind the scenes. So just check, no questions from our people who are following remotely. Yes?
A nursing perspective, it's the one area, and Gráinne and I were just talking about this yesterday, funny, that is very under-resourced in nursing, for nursing supports for all the areas of gastroenterology. So your talk was really interesting, and I suppose there's lots of arguments around a really good business case to support more nurses, to support the gastroenterologist to look after patients. So it's just a comment, really.
I know most of the hospitals have one IBD nurse.
Yeah.
So regardless of caseload, so there's one, and that's not enough.
Yeah. And is there any sort of national funding streams at all for that? Are you aware of?
Well, I suppose from a general research perspective, the diseases that are higher impact on mortality are usually the ones that get the funding first. I mean, that's not a secret. That's just the way things are. So or the ones that are becoming epidemics like diabetes, so that's where the research is going. And obviously, those areas need to be researched. Cancer, diabetes, cardiovascular disease, they need that research funding. We just don't have enough research funding. So we need to find other ways to research, to fund research. And whether that's through philanthropy, whether that's through other type of funding models that we need kind of the HSC or other health providers to take the lead on and trying to find more novel ways to fund research, but there's usually not enough to go around. Now, there is a Network in Ireland initiative led by Prof. Glenn Doherty in St. Vincent's, and that's a network of gastroenterologists who are research active across Ireland. Professor Larry Egan is also involved in that from Galway, and they are trying to do more clinically focused research through getting funding through pharmaceutical companies, through other channels. Now, they find it very difficult as well. I work with them as a patient representative, but also as a health economist. So kind of wearing the two hats. Sorry. Okay, thank you.